If you're okay with it, we're going to try to record this session. So I'm going to start the recording right now. Good morning, good evening, good afternoon.
Recording in progress.
Hello, everyone. Today we will look at interesting coronary anomalies and funny-looking coronary cases. The first two cases will be presented from Indonesia, and Dr. Grafy is going to be the first to present a case. Thank you, Dr. Grafy. Please take it away.
Okay, thank you, Professor. Good morning, Prof, and good evening for Dr. Amal, Dr. Heltara, and other fellow resident. My name is Grafy. I'm a radiologist resident from the University of Indonesia, and I'd like to present an interesting case for today's session. This is a CT cardiac contrast of a 6-year-old female patient who present with concern of regarding poor weight gain and raising suspicious of malnutrition. And she also report experiencing a mild dyspnea during excessive physical activity. And during the pediatrician examination, heart murmur was detected on the auscultation, leading to a suspicion of an underlying disease. This is the CT. First, I will roll down from cranial to caudal in axial plane. Okay, and next, this is for the sternal plane. We can see this the inferior vena cava and the superior vena cava drain to the right atrium, and there is a innominate vein in here, but there is no persistent left superior vena cava. And in axial plane, we can see the right atrium appear slightly dilated, and there is and there is also widening of the pulmonary trunk. And in this case, we can see the coronary artery. There are two coronary ostium. First, here, this is the right coronary artery, rise from the anterior sinus. And the second one is here, left main. This is rise from the posterior sinus. And the left main branch into two branch. First is this is the LCX or left circumflex artery that is very dilated, and left anterior descending, this one. But however, in this patient, there is another branch. You can see here, there is another branch that go to the posterior between the left and the right atrium, rise from the LCX. And this vessel we suspect is the senonodal artery, this one. But it will dilated and forming a saccular aneurysm in this one. And this aneurysm causing a stenosis of the right pulmonary artery. And this vessel is also go to the defect at the right atrial wall. Thank you, Prof. Is there any comment?
Thank you very much, and thank you for moving so slowly. That was very, at least on my end, it was very easy to follow. The only thing I would ask you is if you could show where the circumflex, the left circumflex continues on, the native left circumflex, which is, yeah, exactly in that left AV groove, somewhere there next to the vein. It's really hard to see, but obviously that's where it would continue on. But you're absolutely right. This looks like an SA nodal or sinoatrial nodal artery. Some people call it different names, that has aneurysmally dilated. And
Yes.
the pulmonary vein compression is not very severe. Would you agree with that? The pulmonary veins are not that stenotic. There is some mass effect, but and sometimes I find it easier to look at the effect on the pulmonary veins if you turn sagittal. If you could show that on the sagittal view. Yeah. Let's follow the left atrium. Yeah. So there's our left atrial appendage, so we can follow that back. And then we were concerned more with the right-sided veins, right? So there come the left-sided veins. They're fine. Keep going. There is that. Yeah. So those veins kind of sneak out there. They're displaced more than narrowed. Maybe the inferior one. Yeah. Yeah, I just find that very nice to look at it in the sagittal view. Does anybody else have any comments or questions? Is this the patient that you mentioned turned blue during exercise? Was
Yeah, Prof, but it doesn't turn blue. This got mild dyspnea. I'm sorry.
I'm sorry?
Yeah, this is the patient, but as I check later, the patient didn't turn blue. Just a
Okay,
mild
not this patient. Okay.
dyspnea.
Okay. No problem.
Yeah.
Dyspnea was the main. Yeah, and that makes sense. Like you pointed out, that this would cause essentially a left to right shunt and then increasing pulmonary flow. That's why the right atrium is dilated, and that's why the pulmonary arteries are dilated. And the other possibility that we could entertain here is during exercise that there could be some steal phenomenon from the coronaries, and that could decrease myocardial perfusion. But you didn't say that the patient had chest pain, right?
Yeah.
And you would expect a 6-year-old kid to be able to tell if they have chest pain.
Yeah. I think no.
Yeah, so it's probably not a very significant effect of coronary steal either. All right. Excellent case. Thank you so much for presenting. Anybody has any more questions?
Thank you, Prof.
Thank you, Dr. Rafi.
Prof, maybe I have one question
Yes,
about
please, Dr. Yogi.
this vessel. So, how could we come to the vessel as an sinoatrial artery since it's actually usually coming from the RCA?
Yep, excellent question. Well, we could check and see if there's an SA nodal artery on the right side, and if there's not, it's actually a shockingly high percentage, depending on where you look in the literature. You can find numbers anywhere from 40 to 45% of the SA nodal artery arising from the left circumflex. So it's a surprisingly high number, actually. A lot of time we don't pay attention to it. So that in and of itself is not that surprising, but we would scroll to the proximal RCA and see if there is anything sneaking right there between the aorta and the right atrial appendage, and I don't see a vessel there. So I think still it's very likely that we're dealing with an aneurysmal SA nodal artery, but I'm not sure. We cannot be sure. You are correct in that it most commonly arises from the right coronary artery and goes on the other side.
Okay, thank you, Prof.
Thank you. Excellent question. Yeah. All right, Dr. Grafy, I'm going to ask you to transfer the host role to Dr. Glenn. I think
Okay, Prof.
he's going to present the next case for us.
About the first case, Professor.
Yes.
I think, is it probably because of the sinonodal atrial arteries coming from the LCX, so that's the position is not quite high than the common sinonodal artery that comes from the RCA. Probably that because we see in this patient the location is a little bit lower or to the rather than the common sinonodal artery that comes from the RCA. And also at that time I it's quite difficult. Then I searched on some literature also say some branch of sinonodal artery that comes from the LCX. So that's why I made the diagnosis. It's a dilated aneurysm of the sinonodal artery. Yeah, like that. Yeah.
Cool. Makes sense. Dr. Glenn, can you share your screen?
Okay, good morning, Professor, and
good morning.
Good evening, Doctor and colleagues. Allow me to share my screen.
Don't forget Tanzania. Good afternoon for Tanzania.
Oh, good afternoon, Tanzania.
I see lots of faces.
Okay, this is a cardiac contrast cardiac CT examinations of a 4-year-old male patient presenting with a cyanosis during episode of crying. And in this examination, we can observe several cardiac abnormalities, including ventricular septa defect, and also overriding aorta. And also there is a stenosis of RVOT. And this consists with tetralogy of fellow appearance. But it is noted that if we take a look and more closer in this patient, there is only one single ostium of coronary artery. And this single coronary artery originates from posterior sinus and subsequently trifurcates into the right coronary artery, left anterior descending artery, and left circumflex artery. And if we tracing this coronary artery, it's seen run to anteriorly and subsequently give a rise a smaller coronary artery branches. You can see from here. And then if we're returning to the structure of left circumflexa in here, if we're tracing its course, it is observed to continue posteriorly and encircling the heart towards to the right side. Here. And if we trace it distals, it extends and visualize only up to this point. And this patient is diagnosed with a cardiac anomaly involving a single coronary artery ostium. And this concludes the case presentation I've presented. I look forward for any input or insight from Professor and Doctor. Thank you.
Thank you, Dr. Glenn. Would you do me a favor, please, and scroll through from the beginning of the single coronary like you did, but
Okay.
instead of the MIP, which was very nice that you presented it this way because it was nice to follow the coronaries. But in some of the areas where the vessels overlapped, it was kind of hard to see. So if you could make it into an MPR, I know it's going to be a little bit noisier, but if we could scroll through just for everybody's benefit and maybe zoom in a little bit more so we can all see.
This one, Professor?
Can you make it not a MIP? Because this looks like a maximum intensity projection.
Okay.
See? It's like...
The thickness probably, Dr. Glenn.
Yes. MPR.
MP.
Just click MPR and that should take care of it. Up there, click MPR. Oh,
Yeah,
Okay.
MPR. Yeah.
But do that with the axial. Yeah, very good. And then let's look at that axial this way.
Okay.
Very good. So, yes, we see that single coronary coming around posteriorly, goes around even the pulmonic root. I think Dr. Amal had an excellent point when we discussed this case earlier about that. Yep, that's where it splits into that left circumflex and to that rightward. I don't even know what we should call that. Rightward coronary artery. What would you call that, Dr. Amal?
I call it right coronary artery.
Yeah, I mean it goes rightward. So.
Yeah, it goes right one.
Yeah, so let's Whichever you want to follow, let's follow one of
Yeah,
them.
let's follow one of them. Okay.
Okay. Yeah. And then that goes, yep, right there. The other vessel next to it, just for everybody who's watching, that's a big vein. That's the anterior interventricular vein coming around and becoming the great cardiac vein. But the vessel that Dr. Glenn is pointing to now is that vessel that gives a very, very tiny right coronary and then sort of an anterior descending, right? Let's follow that anterior. Yep, that's the right coronary. And then the anterior descending is bigger.
Up to this point.
Yep. All right. And then just point at the anterior descending one more time for everybody to see. Yep. And that goes parallel to that anterior interventricular vein. Yep. And then gives off. Looks like it gives off branches to both ventricles. Excellent. Yep. That goes in the anterior interventricular groove. So everybody can see it now. Yep. And if we come back to the circumflex, the left circumflex, I guess.
Yeah, this one.
Yeah. That goes around that left SVC or adjacent to the left SVC, right? In the left AV groove, left atrioventricular groove, we left the anterior groove. Now we're in the lateral aspect of the groove, adjacent to the great cardiac vein. And then we also see that big contrast-filled left SVC. Here, things are going to get a little bit motiony and things blur together. But if we keep scrolling down, now we have a big dilated coronary sinus. But behind, if you keep scrolling, you will see behind it that left circumflex will reveal itself once again. There's a little blurring motion there. Yep, excellent. Great job following that. And truly remarkable. Goes all the way around, gives a posterior descending right there, and then goes all the way around and hugs the right hypertrophied right ventricle from below. And after it gave it a hug, it gonna come up in the right AV groove. It's gotta be the longest coronary artery I've ever seen in my entire career. So should go into the Guinness Book of Records or something. Remarkable.
Yeah, to this point, Professor.
Yeah, very nice case. Thank you for sharing. Dr. Amal, I don't want to steal your thunder, but you made an excellent point earlier when we discussed this case about surgical problems potentially.
Yeah, thank you, Prof. Pali. So, regarding the patient with congenital heart disease, that's one of the most important point we did or we are doing the CT cardiac is we need to know about the condition, or we need to evaluate the coronary artery, not only the origin, but also the course, because when we look at this patient, we can see the course of the coronary artery. It's coursing into the right ventricular outflow tract. So that's the most important point, because the surgeon will do surgery or will do the treatment around the RVOT. So that's why we need to mention it to the surgeon that be careful, because there's a coronary artery in there. So they don't cut the coronary artery accidentally. So that's why one of the most important point evaluate the congenital heart disease in CT cardiac. And also sometimes I also mentioned to the surgeon, because if they want to approach surgeon from the medial sternotomy, that I need to inform also the coronary artery that really located. Usually we can see the coronary artery is very close to the soft tissue of the sternum in the anterior. So that's also I inform the surgeon if they want to do the surgery from the medial sternotomy, but it depends on the case usually, and approach of the surgeon. If the surgeon wants to do from the right or left side, it's okay. But if they want to approach from the anterior, that's also the region that I need to inform to the surgeon. I think that's about the coronary artery in the congenital heart disease, Professor.
Yes, excellent points. Thank you very much. And in this case, actually, now that you mentioned Dr. Amal, I noticed that, was there already a sternotomy in this kid?
No, not yet.
Why does the sternum look like? You scroll down on just this one picture, it looked funny.
Yeah, abnormality in the sternum of the patient.
Oh, it's just the developmental.
Yes.
Oh, wow. Interesting.
Yeah. One of the anomaly also.
Huh. All right. Excellent. Thank you very much. Does anybody else have any questions or comments on this case? If not, then if you could please transfer the host role to me, Dr. Glenn.
Yeah, thank you, Professor. Thank you, Dr. Amal.
Thank you so much for the presentation. Excellent. A very interesting case.
So much.
I've really not seen anything like that before. That's the nice thing that we're all learning here. So my case that I would like to show all of you is not as bombastic. It's a little bit more bread and butter, as we would say, a little bit more boring. But hopefully it's going to be beneficial. This is a 16-year-old with exertional chest pain, wants to be a football player, but not soccer, but American football. And as we scroll through, I'm going to immediately go into a multiplanar reformat, as you see. I'm not starting with the regular axial view. I already pulled up the case and set it up where I lined up my plane parallel to the aortic valve in both of these views. So this plane is parallel to the aortic valve, which is here, in both of these views. And I'm going to come up from the root of the aorta, where we can clearly see that this is a tricuspid aortic valve with three sinuses. As we would expect, the non-coronary sinus is straddling the interatrial septum here. The right coronary sinus is facing anteriorly, and the posteriorly and leftward facing sinus is the left coronary sinus of Valsalva. These three sinuses comprise the aortic root. And then we have the sinotubular junction, which is where the sinuses are over and the aorta gets a little bit narrower. And then above that, we would be looking at the ascending aorta. The last thing I'm going to say here is, due to the low radiation dose that we used, the images are a little grainy, but we used EKG synchronization, of course. And you also see a misregistration right here. That was probably patient motion, probably respiratory motion. If you look at the chest wall, you can actually see that the chest wall was moving. So you can clearly see that it's not arrhythmia, but Probably the patient was startled by the contrast injection or just was scared and couldn't follow instructions properly. So nonetheless, we're scrolling through, and I'm sure most of you already noticed that there is something very abnormal here, that we see no coronary artery arising from the right coronary sinus. We see a normal appearing left main arising from the left coronary sinus. But on top of that, we see this other coronary artery that's also arising from the top of the left coronary sinus. We're very, very close to the sinotubular junction here. And not only that, but if you consider the angle here, it's a very sharp angle takeoff from this sinus. It's also a very, very slit-like orifice. It has a very narrow proximal course that's interarterial because it's running between the aorta and the main pulmonary artery. But not only is it interarterial, it's probably intramural, meaning it runs in the wall of the aorta itself. And then I'm going to use the trick that I think Dr. Glenn and Dr. Grafy both used to make it into a myth, to make it more enjoyable and prettier for everybody. So I'm stealing your tricks, gentlemen. But if we follow this right coronary artery, we see a nice acute marginal branch there, a little bit of motion here and there, but we're going to follow this vessel down here. And then we can see faintly, but distally also can see that this is probably a dominant right coronary artery. So I'm going to come back to it once more. And I'm going to point out to you what's, I think, super helpful when I'm describing these coronary anomalies is I go in the center of the aortic root or the aorta, and I try to rotate. And even though I'm rotating here, my eyes are going to be up here on this image. And that way I can demonstrate the relationship of the left coronary ostium, which is normal, a little bit too high in the coronary sinus, but it is considered a normal location. And then as I come, I can see that it's very, very narrow, slit-like orifice, and it's kind of an ovoid shape. You have to use a little bit of imagination. And that it runs in the wall of the aorta, and then it comes out, and lo and behold, now we are in the epicardial fat. But you can see the difference of the right coronary artery. Even the caliber of this coronary is significantly reduced proximally. It's about 2 millimeters here. And then if you go back to its origin, it gets really narrow here, especially sort of in this dimension. It's narrower than in this dimension. Oh, I can't even. You guys get the idea. So it's a little bit wider this way than in this direction. So it's kind of becomes ovoid in that sense and narrowed, as it's not only interarterial, but also intramural proximally. And this is very important to describe for our surgeons, the intramural segment. Also the location with regard to how high it is from the sinotubular junction, how close it is or how high it is here in from the level of the annulus. But one of the things that they can do in some of these cases is remove this area, which they call the roof, and it's called unroofing. And if they remove this area, then they can sort of create a bigger coronary ostium right here without the need to take off the coronary and reimplant it, or without the need of bypass grafting. So it's a little bit less traumatic to the system, and that's called unroofing, that they can do in patients like this. and sort of cure the problem at its origin without really needing to move the coronary artery or needing to put a bypass graft. So this is intramural and interarterial coronary origin. This, by some people, it's considered a malignant variant. We don't like to use that terminology in our pediatric population with our pediatric cardiologists because you know, it's scary to the parents and the patients. We just described that it's interarterial, and when a coronary anomaly is interarterial, it can actually lead to significant reduction of blood flow in that coronary artery during exercise when the cardiac output increases in both great vessels, and maybe their orientation might even change a little bit, and there could be a kinking phenomenon and a compression phenomenon that would lead to reduced flow in this right coronary artery. And like we said, in many patients, the right coronary artery is actually dominant. It's responsible for the SA nodal branch supply. It also can be responsible very commonly for the AV node. So very, very important vessel that could lead to problems. Any comments or questions?
I have a question, Prof.
Yes.
About the interarterial course of the coronary artery. Do we need to look whether it is interarterial or a subpulmonic course? Because
Oh, you mean like when it goes into the septum, like here?
subpulmonic. So the interarterial course of the coronary artery is below the pulmonary valve.
Uh-huh. Yeah.
Yeah.
Yeah. So it would be coming here. Yes.
So
Maybe, I mean, obviously it's important to describe. I'm not sure exactly what you're getting to.
no, if we find the interarterial course, so during the systole, the coronary artery will be narrowing because of the
Pulsation in the great arteries.
yeah. But for the subpulmonic, but the course is interarterial, but the location is subpulmonic, so below the pulmonary valve. So probably the coronary artery will not narrowing or stenosis during the systole phase.
I see what you're saying. So you would look at this image here
Mm-hmm.
and like locate the pulmonic valve.
Yes.
Or no, actually, so that's not the pulmonic valve. This is the pulmonic valve here. Right?
Yes.
This is our aortic valve.
Mm-hmm.
This is our pulmonic valve. And you
Yeah.
would describe and note the origin or the location of the interarterial course, whether it's above or below
Yeah.
the pulmonic valve.
Yeah.
Right. And that's what I was, sometimes that's referred to as intraseptal course,
Yes.
because then what you're dealing with sometimes is that it's running in this muscle, because this is, I mean, I don't know if I can show you, but this is actually, a lot of this is myocardium, right? So then you
Yeah.
might end up with a vessel that's running in this myocardium here and sort of underneath the pulmonic valve. I think. Yeah. So we can also look at it, I guess. Let's look at it this way. Let's see if we can go from the pulmonic side. And so, by the way, if you're looking for the pulmonic valve, one of the tricks that I sometimes use is because the pulmonic valve is so thin, especially in children, it's hard to see, right? So I look for the myocardium. Where the myocardium ends is one clue. And the other clue is the pulmonic root also has sinuses, right? So even the pulmonic root, if we go into this view, trying to rotate it so you all can see why it's not cooperating fully. Trying to show you the sinuses. Maybe I need to reset this because it's not doing what I'd like. There's also some misregistration here, so I think that's partly why I'm having a hard time aligning things. So this would be the RVOT. The muscle ends right here. You see a little bit of outpouching for the pulmonic root here and here. And then this would be the en-face view, but unfortunately we also have a little bit of misregistration right at this level. So, and this is what I think Dr. Amal was pointing out, that you would look at the origin and the course of this vessel and see whether it's above or below the pulmonic valve. Am I getting your point right?
Yes, yes.
Is that what you wanted to say?
Yeah.
But pulmonic valve is sometimes really hard to see, and you have to use a little bit of imagination. Like here, you can see it right here and over here. This is the level. And here we have a little bit of misregistration, but you can sort of see the pulmonic sinuses. All right. The next case I wanted to show you all is this one. I'm going to let you just stare at this for a second and try to test yourself if you could come up with the diagnosis just from this view. It's not a fair question, but I'm just trying to keep you engaged a little bit. And I will tell you as much that this is actually a 65-year-old gentleman. This is the right ventricle and this is the left ventricle. So there's nothing majorly abnormal with regard to the cardiac chambers per se. Coronaries are definitely abnormal. We're going to go to the axial views now. Coming from the pulmonary artery here, ascending aorta over here. Scrolling down slowly. Getting to the level of some coronaries here. Here's our pulmonic valve. I'm going to use Dr. Glanz and Dr. Grafy's trick. So this is certainly very, very abnormal, right? We have a pulmonary or a coronary artery arising from the main pulmonary artery that goes a little bit interarterial, but mostly, as Dr. Amal pointed out, mostly it's going to be subpulmonic. Does have these branches. This would be a conus branch where it's close to the sternum, so that's probably something that you could mention as well. And then we start seeing a tangle of lots of funny looking vessels here. This would be the location of the SA nodal artery here, because the SA node usually lives up here where the right atrial appendage and the SVC meet, medially in the right atrium. We see that some of these vessels get entangled here, posterior to the aortic root near the left atrium. I'm going to go back to the right coronary artery here, try to follow that. Really, really dilated. In adults, 7 or 8 millimeters is definitely considered aneurysmal. Now it's even bigger. 9 millimeters. And then as we follow it, we can actually, in some areas, see that there is a suggestion of maybe even communicating with the ventricular chamber, like some sinusoids. If I remember correctly on the echo report, it was actually mentioned that in this right coronary artery, there was reversal of flow. The other thing to notice here is that also the left main is fairly large over here. And the LAD and the left circumflex are also fairly prominent. And maybe by measurement, you can almost, they're getting close to being aneurysmal. And we also see that some of these branches might be trying to communicate with the ventricular chamber. Or getting very, very close. So one of the things that happens with anomalous coronary arteries from the pulmonary artery is that they develop what are called coronary sinusoids, at least around here, that's what we call them, where these vessels are stealing blood from the ventricular chambers and then end up with retrograde flow into the pulmonary artery because the pulmonary resistance is going to be lower than the resistance in the normal coronary bed, in the normal coronary network, coronary artery network. And a lot of these patients end up with retrograde flow into the pulmonary arteries and eventually can develop heart failure that way. So the most important finding here is the anomalous coronary from the main pulmonary artery. It's the right coronary in this case, but it's important to note that these other coronaries are also aneurysmal and may have communication with the ventricular chambers. Now, in this case, it's a 65-year-old patient, so he managed to live a long life with this finding, so it's kind of remarkable. Does anybody have any comments? No comments. I'll show the patient in a coronal view as well. Look at that left main, how big that is. This is a right coronary artery arising from the main pulmonary artery. There are some misregistrations here, of course. For the right coronary here in the AV groove. Yeah. No comments?
Hi, Professor.
Yes.
Can I ask? I interested uh, about your acquisition for this patient with
Mhm.
the contrast injection. So you can see bright contrast enhancement in the right heart. So do you perform this exam in advance? You know that will be a fistula between the in the heart and left pulmonary circulation. So if you just order a normal coronary study, you may look the coronary with left heart enhancement. So you will trigger the contrast when it reach the aorta. What do you do in this patient? What did you do?
I think in this patient,
For
we were unaware that this was going to be the finding. So I think we probably primarily aimed, let's see, actually, no, I'm looking at the exact history. It looks like actually this patient came through maybe the emergency room with chest pain, and I wonder if we scanned the whole chest. Actually, yes, we did. Okay, so this was more of a triple rule out, actually,
oh,
that
I see.
sometimes do. And in those cases, we try to ensure that there is still contrast in the right-sided system. And actually, I have the contrast injection protocol here. Hopefully, this is not going to have any. Well, I'm going to hide the patient's information, but here you can actually see the contrast injection protocol. So A is saline, or no, maybe A is contrast, I believe. This was a long time ago, so we might have had in 2012. This might be at a time when we still used a test bolus. So this 20 cc's of injection must have been a test bolus. And then we measure the arrival of contrast to the aorta and or the pulmonary artery. We actually used to plot these and then select the delay time accordingly. And then after the contrast injection, the first, which is clearly just contrast, we have a 50-50 mixture that we chased the contrast with, and then we had some additional saline. So this was like a triphasic protocol. And I know that some people do that to get right heart injection or right heart enhancement.
Yes, thank you. So I think it's a very good lesson for the audience. I think if you want to see both enhancement, good right heart and left heart, you can do this triphasic protocol injection with second contrast injection, probably with some literature can make a slower injection rate, and maybe just 2 or 3 cc per seconds.
Right.
But as
You could do
you do
that
this, it's like
instead of the 50%.
yes,
Yes.
very good.
Excellent
Thank
point.
you, Professor.
Yeah, thank you. Thanks, Dr. Helter. That was a very good point. Yes. So this was sort of completely incidental loaded. I think the patient had chest pain, but yeah, chest pain and had some head injury. So maybe he passed out or something. This was a case from actually 2012. All right. I have one more case. I know our time is going short, but it's interesting. So I'll be in a hurry with this one. I'm gonna go a little bit faster, but this is just interesting because originally this case was noted first on cardiac MRI. The finding. This is actually an 80-some-year-old patient, a very older patient, and we noticed. Hold on a second. Hopefully I can back to the salient image quick. Yeah. Yes, this is going to be our images. So this is a first pass perfusion. sort of closer to the base of the heart. Just routine, not stress, just resting first pass perfusion. Patient had history of hypertension, and I'm just trying to see the indication here. Chest pain, and they were hearing some murmur, and they were wondering if the patient has a patent ductus arteriosus, like a sort of a continuous machinery murmur, and has history of hypertension and presented with chest pain. And as we're injecting in our cardiac MR examination, the first pass of the contrast through the system, we see the contrast arrive to the right ventricle, then it arrives to the lungs. You can actually see that even the lung parenchyma is enhancing. Then through the pulmonary veins to the left ventricle. So far, everything is fine. But as I was reviewing the first pass perfusion images, I noticed that there was an arterially enhancing tangle of vessels here adjacent to the RVOT and in the anterior AV groove. So notice that these vessels light up exactly, almost exactly at the same time as the left ventricle. But of course, our spatial resolution wasn't good enough. And these findings weren't really well visualized on any of the other views. We did see what looked like could be a sort of a dilated left coronary artery here. But certainly in a case like this, the best next step is to just go to CT. So we did that. And I'm going to go from the top so everybody can get their bearings. Going from the main pulmonary artery, you already noticed that there are some serpiginous vessels, some really dilated vessels here, just adjacent to the main pulmonary artery. Here you see an actual communication with these dilated vessels. Keep scrolling down. You also see some calcifications within the vessels. This is our pulmonic valve. And it seems that all of those vessels connect to the proximal aspect of this LAD right here. And that the proximal LAD is aneurysmal because it's up to 8 millimeters. And then here we have the left main. If I make it a MIP, hopefully you can follow these serpiginous vessels better from the LAD all the way back to the main pulmonary artery. So this was sort of an incidentally noted malformation. There's also questionable connection here with the conus branches toward the right coronary artery. It was not really clear to me whether those guys are connected, but the connection between the LAD and the main pulmonary artery, this arterial fistula, is definitely something that we were able to explain her symptoms and her murmur. That's sort of a continuous murmur, kind of similar to what you would hear with a patent ductus arteriosus, because there is arterial pressure in this dilated proximal LAD, and then there's going to be a continuous flow into the pulmonary artery and shunting. And this is what it looks like on 3D volume rendering. This tangle of vessels sitting in front of the main pulmonary artery. This is the left atrial appendage. This is the ascending aorta. And that's all I have for today. If there are any questions or comments on this one. No comments. Everybody's tired of coronary anomalies. Good.
Very interesting cases.
Yes,
Oh,
thank
it's
you.
interesting. Very interesting. Thank you, Prof.
Thank you, everybody. This was an excellent review of interesting cases. Thank you for the contributions, Dr. Amal and Glenn and Grafy.
You,
Thank
Professor.
Thank you, Prof.
Thank you for Dr. Pinkan promoting this. And hopefully in the future, we will have presentations from also Tanzania. We're working on that. And I think in 2 weeks, we will reconvene. And the theme is going to be, correct me if I'm wrong, is it going to be airways, Dr. Amal?
I think yes. Is it correct, Dr. Pinkan? I think Dr. Pinkan has the list.
And airway effects.
Is it correct,
Thank
Dr.
you.
Pinkan? Coming even. Yes, it's lungs and airways anomaly.
Yes, and as they affect the cardiovascular system.
Yes.
All right, should be interesting. In 2 weeks, see you,
Yes.
everybody.
See
Thank
you,
you for your
Prof.
attention and thank you for your questions and contribution. This was excellent. I learned a
Thank
lot.
you, Prof. Thank you.
Thank you,
Good
Professor.
morning.
Thank you.
Have a nice
Thank you,
day.
Prof.
Have a nice
day, Prof.
Thank
Have a
you
nice
so
weekend, everybody. Thank you. Bye-bye.
Thank you.
Oh, I need to stop recording.